Let's look at the problem. In 2005, New York City was facing a diabetes crisis. The disease was killing thousands and blinding many more. The burden was falling heavily on low-income, Black, and Hispanic communities. The health department, led by Thomas Frieden, looked at the data and saw a failure of the medical system. Patients were not being managed well. Physicians were overwhelmed. The voluntary, education-based approach was not working. People were still dying. The health department decided that the sheer scale of death constituted an emergency, justifying aggressive government intervention, usually reserved for plagues. They decided they needed to know exactly who was sick and how sick they were. Here is the policy they enacted. They mandated that all laboratories in the city report A1C test results directly to the Department of Health. An A1C test measures your average blood sugar over 3 months. It is the gold standard for tracking diabetes control. If you went to your doctor and got blood drawn, the lab would send your name, address, and test result to the government, whether you wanted them to or not. This was the first time an American city created a mandatory registry for a non-infectious condition. The government was inserting itself into the private doctor-patient relationship on a massive scale. The registry wasn't just a list, it was a tool for action. The health department planned to use this data to intervene. If a patient's A1C was dangerously high, say above 9%, the computer system would flag it. The department would then send a letter to the treating physician, essentially saying, "We noticed your patient John Doe has uncontrolled diabetes. Here are the latest guidelines for management." They also planned to send letters directly to the patients, offering advice and resources. The idea was to act as a backstop, a safety net, ensuring that no patient fell through the cracks of the medical system. They viewed this as a benevolent service. The backlash was immediate and fierce. Privacy advocates, civil liberties groups, and medical societies screamed foul. Their primary argument was simple: diabetes is not contagious. You cannot catch it on the subway. Therefore, the state has no compelling interest to violate privacy to protect the herd. They argued that the police power logic of Jacobson applies only when my illness threatens **you**. If my illness only hurts **me**, that is my private business. They also feared the slippery slope. If the government keeps a list of diabetics, who else will get on that list? Insurance companies? Employers? They argued that this surveillance would cause patients to avoid testing out of fear of being put in a government database. Now let's play the role of the bioethicist and run this through our justificatory conditions. First, effectiveness. Did it work? The data, retrospectively, was mixed. There were modest improvements in A1C levels across the city, but it was hard to prove that the registry caused them, rather than general awareness campaigns. The intervention was expensive and intrusive. If the benefit was only marginal, does it pass the test? This highlights the difficulty of effectiveness. Sometimes you don't know if a policy works until you try it, but by then, you've already infringed on privacy. Second, least infringement. This was the biggest point of contention. Critics argued that the health department could have tracked the epidemic using de-identified data, knowing that a 50-year-old male in this zip code is sick without knowing his name. That would have protected privacy while guiding resource allocation. The health department countered that they needed names to send the letters to do the actual intervention. However, the program initially launched without a robust opt-out mechanism for patients. Critics argued this violated the principle of least infringement. A voluntary or opt-out system should have been tried first. Third, public justification. While the health department held hearings, the message didn't reach the street level. Many patients were shocked when they received letters from the government about their blood sugar. They felt watched, They felt judged. It felt like Big Brother was in the exam room. This lack of clear, broad public justification damaged trust. Some patients reportedly stopped going to the doctor because they didn't want the government involved. This illustrates that even a benevolent policy can fail if the public perceives it as creepy or overreaching. You must prepare the public mind before you intervene in their private lives. This case represents a fundamental philosophical shift. The health department argued that because the public, via Medicaid and Medicare, pays the vast majority of the costs for diabetes care, the public has a financial interest in ensuring that care is effective. They argued that in a modern healthcare system, there is no such thing as a strictly private disease because the costs are socialized. If your unmanaged diabetes leads to an amputation that the taxpayers pay for, the taxpayers have standing to nudge you toward better management. This is a powerful, utilitarian argument that expands the scope of public health far beyond the original logic of Jacobson. But where does it end? This is the slippery slope. If the state can monitor your blood sugar, why not your body mass index? Why not mandate weigh-ins? Why not track your credit card purchases to see if you are buying cigarettes or soda? Once we accept that non-communicable diseases are a matter of state security, the boundaries of privacy dissolve. If the justification is reducing healthcare costs, then almost any private behavior, from skydiving to sitting on the couch, could theoretically be regulated. The NYC A1C Registry forced us to ask, is the goal of public health to create a safe environment, or is it to perfect the human being? The registry still exists today, though it was modified to allow easier opt-outs and more privacy protections. It stands as a precedent. It proved that the public will essentially accept chronic disease surveillance if it is framed as help, rather than policing. This case leads us directly into our next lesson on paternalism. The health department acted like a parent, stepping in to manage the health of citizens who, in their view, were not managing it well themselves. Was that an act of care or an act of condescension? Join me in the next lesson as we explore the ethics of the nanny state.